For those of you who don't know me, Al Gresch, I worked at Aurora Healthcare for 35 years. It was 15 hospital system in the Midwest. Rob and I worked together there for a number of those years and developed some pretty innovative solutions. Rob?
Rob Bundick, I'm the Director of Biomedical Engineering and Healthcare Technology Management at ProHealth. We're a smaller 4-hospital system, 15 clinics. We run a full asset management in-house biomed program.
So, thanks, Rob. So, well, let's try it with the clicker. That's interesting. Let me start it over again.
We can't get it to change.
There we go.
Oh, there we go. The space bar?
You're just gonna have to use it with this down here. Okay. Thank you all for coming. Obviously, there's a lot of interest in healthcare finance. I recall back early in my career, I started out as a technician and worked my way up to department manager, and I knew squat about finance. And so I got together with my finance director at the hospital I worked at. So would you be willing to spend a little bit of time with me, helping me understand what your challenges are? And he was graciously willing to do that. And I learned a lot in the time I spent with him on what kept him up at night, and it helped me understand the things that I could do to help him, and as a result help our entire organization. And so let's start with, here we go. One of the first things I learned was about operating margins. Operating margins are their total operating revenue minus total expenses and divided by operating revenue. Typically, revenue runs around, margin runs around 2% in not-for-profit healthcare organizations. I remember when I was at Aurora that we were targeting 2.5% as the margin. Now you compare that to most businesses. There's companies represented here, and you're trying to hit 30, 40, 50% margins on your business. So when you compare that to healthcare margins, they are razor thin. Then you look at what happened during the pandemic. Right, pre-pandemic, those margins dropped to 1.6%. And during the pandemic, dropped to 0.5%, with 30% of not-for-profit hospitals being underwater. Okay, that's crazy, right? So you understand what CFOs are dealing with. The CARES Act during coronavirus helped keep a lot of healthcare organizations solvent, right? But outside of that, they would have had a lot of challenges. One thing I always want to call out when you look at these kinds of margins, if your hospital is operating at a 2% operating margin, if you save that organization $1 million off the bottom line, they would have to generate $50 million in new revenue to have the same bottom line impact. That's difficult, if not impossible. You look at the 0.5% margin, if that's where you're at, you would have to generate $200 million in new revenue in order to hit that same bottom line impact, right? So I call that out because if you're dedicated to doing it, saving $1 million operationally is not that hard. You have to be willing to kind of step outside your comfort zone. Rob, I know that has done that numerous times at ProHealth as well. So you have the ability to have a significant impact on your organization if you're willing to step outside that box. Revenue centers versus cost centers. Revenue centers are like all of your clinical departments are revenue generating departments, okay? Support departments like HTM, EVS, facilities engineering, are cost centers. And because of that, CFOs do all they can to drive those costs down as much as they can, including outsourcing, right, as a mechanism to drive those costs down. So once again, if you're partnering with your finance group, you understand the challenges that they're facing, and you're willing to do whatever you can to help minimize those costs, you ought to be able to hold yourself up as somebody who brings solutions and somebody that they know that they can depend on. I just brought in a couple of slides. This came from Definitive Healthcare Hospital View, where they showed in 2022 the average operating margins across different hospital sizes. And as you can see, none of these show very good numbers, right? Smaller hospitals a bit more challenged than larger hospitals, but you know, in 2022, all of these that we're showing here, the average were in negative numbers. And then here by region, you know, again, the Midwest wasn't too bad, but the Northeast, where we're at right now, was hit pretty hard, right? So I thought it was important to show these as give you understanding of what your CFOs are looking at, right? And what keeps them up at night. Okay, so here we are in 2024, and things have gotten better, right? The average operating margin has jumped up now to 3.8%, which is good, right? That's outstanding. However, they are now faced with other challenges, right? Inpatient and emergency room volumes dropped 20% in 2023 compared to 2019, right? So they're dealing with that, and yet with that, they all expect the outlook to be fairly good from a financial standpoint. However, other challenges have come to light, right? How many here are dealing with cybersecurity issues within your organization? I mean, lots of them, right? 86% of hospitals and health systems expect increased technology budgets in 2024 to deal with those cybersecurity challenges. The average cost of healthcare data breach in 2023 was $10.9 million. So you think CFOs aren't looking at those numbers and trying to figure out how to deal with that situation? Since 2010, healthcare has continually been the largest hit group or industry relative to cybersecurity and ransomware. So 66% of hospitals and health systems operated maximum capacity in 2023 due to ongoing staff shortages and workforce issues. Preparing for this session, I talked with a friend of mine who's a former CFO at Aurora. We worked very closely together, and that was one of the things that he brought up, that he was dealing with staff shortages. How do I continue to operate when I can't find people to do the work? Okay. So let's talk about operating budgets. Most organizations do a fiscal year operating budget, and your budget cycle is sort of driven by how your finance group wants to run that. Some, it's a calendar year. After I left Aurora, I went to work for another health system running their capital supply chain group, and it was a nightmare because we were on a fiscal calendar year. And one of the cardinal rules of capital is you never fail to spend all of your capital, right? And so we get to the end of the year and we had this money left to spend, and we had to spend it, right? And you'd be amazed at the shenanigans that we pulled in that regard, where we wanted to buy something, and the rules around that is you have to actually receive the equipment in order to book it, right? Well, what I had some companies do, and I probably shouldn't even be telling this, but what I had some companies do is ship me something, anything that I could book as received, and I said, then we'll straighten out what we really want to get after the fact, right? Right? I mean, but we spent our capital, right? We spent our capital. So what a lot of organizations have done because of that is they switched their fiscal year to like July through June, right? So you don't have this panic at the end of the year. But in any case, you do your budget planning. Typically it starts about 6 months prior to the start of the budget year. I remember we actually started in about, was it maybe May, figuring out what we needed for the coming year. And if you're smart, you'll do your performance reviews early in the year so that you have all of that information in pocket as you're planning for budget for the following year. Okay, so we would do everybody's performance reviews. We would look at what we needed in terms of training. You know, we'd ask people, you know, what do you want to be when you grow up? Where do you see yourself in 5 years? And how does that align with our department's goals and where we want to get to in the coming years? And then subsequently, we had the ability to take that information and plug it into our operating budget requests for that year. You look at things like contracts, training, staffing for the coming year, and I'm going to go into much more detail a staffing plan that we ran every year at budget time, and you'll see how that benefited us. There are a number of different ways to create operating budgets. One is historical. Typically what they'll do is take a 3-year run of the previous 3 years operating budget, average that, and take your annualized year to date and incorporate that, and then that's what you get as a starting point for your budget. Another way is zero-based, which is you start from zero every single year and have to justify what you need, everything that you need. What I always suggest is whether you're historical or zero-based, that you run it as if it is zero-based, because then you can defend everything that you need in your operating budget for the coming year. Okay. Cost of service ratio. Who in this room understands what their cost of service ratio is in your department? A couple of people. Okay. Do you know what that is? Okay. Well, Rob's going to talk about that, but then we're also going to run through the general ledger or GL accounts, and we'll go through that in a little bit more detail. But Rob?
So, like Al said, one of the tools we use from an organization is our cost of service ratio. It is essentially your annual cost of your service maintenance divided by the original cost of the asset. So looking at your total inventory count, what does that inventory, dollar amount look like? Divide it with your cost of your service for that year, and that gives you your ratio. Typically what you want to see with an organization that's high performing is somewhere in that 4 to 6% ratio. OEMs, when they build their service contracts, 10 to 15%, right? So being able to provide that service yourself and do it for your organization gives you the ability to actually save that organization that money that you need. So
with your annual cost of maintenance, are you taking all the soft dollars into account, or are you just strictly hard dollars?
Soft dollars as in?
Employee expenses.
Yes.
Their part of their sick time.
Yes.
Part of their vacation days.
So one of the things we do at ProHealth Care is we actually have 2 departments. We have a biomedical engineering department that is purely service. And then we have a healthcare technology management department, which is actually ownership related. So cybersecurity, device integration, capital planning, projects, anything that's not service related is budgeted at a separate department. So I can actually take my full cost of service by looking at my budget for that department to say, this is what it takes to service equipment top to bottom. Salaries, training, test equipment, supplies, vehicle expenses, all of that is actually budgeted within that department. So I know what my expense is.
Yeah, it does need to be all in. And what I often tell people too is don't get so hung up on the number, right? I mean, you hear a lot of debate about, well, should I use list price for the acquisition costs or what I actually paid for it?
Yeah.
Doesn't matter. Pick one and go with it, because what you're trying to do is target improvement year over year.
Yeah. So, well, one of the challenges with this we found is that a lot of organizations, especially if you come into an organization, Do they historically have what that cost is in their CMMS system? And most organizations don't. So you have to spend a lot of time getting there. There is, however, one other tool, which is your operating expense ratio, right? So it's essentially the same thing, right? It's the organization's overall operating expense by the number that you are spending for that. That number typically at a high performing organization is somewhere about 0.7 to 0.9% of what the overall organization's operating expense is. That's an easy number to get. You have a relationship with finance, you go to finance, you get what that organization's operating expense is. You can then start looking at what your costs are and able to monitor that. That's, again, high level. Typically, if you see, a 2% operating margin off of $1 billion, there's an impact there that you can actually go in and save the organization money. So we talked about some of those dollars of what those look like. Here's an example of, the previous life at Aurora, some of our supply codes from what we use and where some of those expenses are. And you can see the heavy items, right? Some of them are very small, some of them are very large. The easiest thing to do, low-lying fruit, right? Take your largest dollar amounts, start focusing on some of those areas. Some of our other expenses. A lot of these are typically related to the cost of what we have for servicing equipment. Highest numbers there, outside services, parts, training, those types of dollars, right? So when you start looking at saving money and where those opportunities are and having the conversations with your CFO executives, this is where you can start making the impact. Being able to have this data is key though, right? How do we capture this data? How do we make sure it's in the right bucket? You can't manage what you don't know. So once you have this information, then it becomes valuable for you to start being able to pull those types of information together. So,
Question.
Just as someone who obviously is in that position now, right, or has been at certain points, what is your best advice for someone that is trying to speak with other hospitals? Like how do we get right to that conversation? You know how sometimes it's like a difficulty to get to that point, like there's sometimes barriers. What is like
the hardest barrier,
key words that you would say maybe?
So the hardest barrier is actually getting in front and getting that executive's attention, right? Executives have a lot of things on their plate, right? They to get their attention, you actually have to be able to show them that there's value and that there's savings, right? Savings always gets their attention, right? I can save money, but what's the value you're providing to the organization, right? If I can save you money and provide a value, then you really start grabbing their attention. Don't wait for them to come to you. I tell them, knock the door down. Start pushing that information to them. Start force feeding it to them till they get to the point that they trust you and they want to have that relationship to you. That's when they start coming to you.
I also found that the magic number is $1 million.
Yeah.
If you can get north of $1 million in savings, wait, what? $1 million? Now you have their attention.
Because you said that's $50 million in revenue.
Yeah.
Yeah.
That's wild how the ratio works.
Yeah.
Thank you.
One thing I want to call out relative to this too, before I go on to staff, talk about staffing, is how many people have real strong relationships with your supply chain group? Some, okay. I will tell you that the easiest way to have an impact on this stuff is to be at the table when they still have capital dollars in hand, because that's when you have all of the leverage to negotiate on contract costs, on parts discounts, on T&M labor discounts, all of that. Good luck trying to negotiate those things with any degree of success after you purchase that capital, right? I always stress that is a very key way to have that impact very easily. Okay, how many people have trouble getting additional staffing? Yeah, lots of us, right? This was a report that I generated every year at budget time. Always the expectation was that you do more with less, right? We really want you to keep your budget flat year over year, right? To which I would respond, you want to keep our budget flat? Stop buying stuff, because we averaged 10% increase in inventory year over year, right? That stuff's not going to maintain itself. There are costs associated with that. That's where this report came in. So the first thing you'll see in big bold there, productivity. Submit to your CFO that number. Adopt a productivity metric that the organization supports, because what that does is establishes that I can't absorb anymore. I'm already at 100% productivity, right? I can't absorb anymore, okay? And so all of this equipment that you added, and you could see region by region, we reported out what the net adds were. So this was all of the stuff that we retired, and it's so interesting how finance people think. The assumption is that for every new piece of equipment that you bought, you retired the same number. That never happens, never. Like I said, we averaged 10% inventory growth year over year. So by region, we showed how many net equipment devices did we add, and what were the associated device hours, okay? So we added all of that up. You look down at the end, the system total, you know, for these different, and we broke it out by equipment areas, so general biomed specialty imaging, 2 different imaging groups, and came up with a total number of devices and device hours, and then the associated number of FTEs that we would need to support that. Because again, let's go back to the productivity thing. I can't absorb more, okay? So you've added this equipment, has to be maintained. I have 2 ways to do that. Either I outsource it for this much, or give me the people that I need to do it for this much, and guess what? I'll do better. I'll give you better response time. I'll make sure that my people are trained to support that effectively. So that's, you'll get dual benefit, right? I never, ever got turned down for adding staff using this model, okay? But I didn't stop there. If you look down here below, what you do is you take that total number of hours and you divide it by the available device hours per technician, okay? The average in our industry, if you don't know, is about 1,000 annual device hours per technician. I want you to think about that. Out of 2,080 hours for an FTE, only about 1,000 is actually spent turning wrenches. If you use 2080 as your divisor, you are cheating yourself immensely, okay? But you can also use that metric as an opportunity to show your CFO that you're constantly working to improve. So you can see that this particular year, and by the way, when we started this, we were at about the same as the industry average at about 1,000. But we worked to improve that every year. We looked at everything that we were doing and looked at ways to improve efficiency, including things as simple as meeting time, right? So we pared that down. We got real crisp with our meetings, had a very crisp agenda, and we shortened them where we could. Anything that we could save time on, we did that. This particular year, we were at 1,230 annual device hours per technician. When I left Aurora in 2011, we were at 1,550 annual device hours per technician. Rob, I think you're about at that point, right? Right. Yeah. So I want you to think about that for a minute. How much additional work you can get done at 1,550 annual device hours per technician versus 1,000, okay? And by the way, this had dual benefit. Not only was it a good thing for me to report to my CFO that, you know, if I had continued to do things last year or this year the way I did them last year, I would have needed, you know, whatever, 5.32 FTEs, but because I'm now at whatever it was at that time, 1,300 something, I can name that tune for 5 or 4, whatever it would be, right? So I'm giving them confidence that I'm working my tail off to improve efficiency, right? That is huge. And then down here, you know, we showed inventory growth, and this particular year was a low one. We were at 7.22%. We averaged about 10. Any questions about this? Does that make sense? Yes.
What do you think the maximum you can get out of that device hours would be? So you got to 15. And then the second question would be, how do you measure it? How do you actually want to get that?
Yeah.
How do you know you're at 15?
Yeah, we'll show you detail on how we calculate it. What you do essentially is you categorize your codes, your work order codes for those things that are specific to fixing equipment or fixing the customer, right? And everything else is non-device hours. Okay, so Rob will cover that. So anyway, this is just an excerpt from a report that we ran with our manning data. So you can see for every device category, we had a count of the active inventory, what the hours per device were, and then the total, and that's what fed into that other report that I just showed you. And I think that's key to justify your staffing and what you're doing, right? What I have found always is that people in leadership, executive leadership positions respond well to data. Okay, Rob?
So here's just a couple examples that we use, just an overall dashboard for our organization. So this is just a quick snapshot in a dashboard we use for both departments combined from our organization from the standpoint, right? It gives you information you need when you start looking at your equipment inventory, what the total cost of that is. Average device hours per tech. Our organization has always balanced two, device hours and the average device per tech. They come to us years ago and said, we want to see you at that 1,200 number. And I said, well, what if I can, be better at that? What if I can get us to 1,300, right? If I'm using my device hours and I was originally at 1,200, and now for the past 3 years, I'm pushing about 1,550 device hours per engineer, that gets me from 1,200 devices on average per tech to 1,300, right? So you can see as we sort of bounced back and forth over the years, but then now for this year, we're trending right where we want to be. We've gotten where we need to be from where we want. Again, I'll talk about productivity from a technician standpoint. Previously in our organization, the way the productivity model was is we were punished for overtime, right? You had a budget. If you spent more than those budget hours, the number of hours servicing equipment, it lowered your productivity in our organization's eyes. I sat down and had a heart-to-heart conversation with our finance department and said, hey, if you want me to hit that 100% and only work those X amount of hours per year or per week, then I have to outsource this equipment for repair. And that's going to cost the organization more, right? So we have a choice. Do I take the hit on productivity and be less productive and save money? Or do we come up with a model that says those overtime hours are now additional productivity and it pushes us up over that 100%? And finance agreed with that. So we started that model saying, all right, we have our budget of hours. Anything that's overtime is additional productivity for our department. We're saving the organization money, but our technicians are working more than they have to actually get there. So we need to be credited with that productivity level. So you can see that trend. That goes to our model when we're staffing, right? Our goal is 100% productivity. We don't want our technicians working overtime. We understand there's some cases where they are, but working overtime should not be a standard. You should not have to work overtime to get PMs done. You should not have to work overtime to get regular repairs done. Overtime should be meant for 3 o'clock in the morning, you get an emergency service call. You have to take care of that. That's what your overtime should be for. So we've gone that model. It actually helps when we look at adding FTEs. We take our device hours, we look at the number of devices we have, we look at what our productivity is and say, is this enough for us to justify an additional FTE? We take that up to finance, we show them, they agree with us, we get that FTE added. Total number of service tickets is just a general idea. Finance loves numbers. You show them that number. Again, inventory number is decreasing, work orders are staying the same. Those are all different, right? A lot of that is PM service. You can have a bad year, right? You can add 1,000 thermometers to your fleet inventory, right? Each one of those is a work order if you're checking them in. So that number is hard to actually kind of gauge and maintain, but it's there just as a reference point. And then what our combined operating expense for the organization, and then that cost to support ratio. I talked about having an operating expense ratio for the organization, but now we have a support ratio, right? I bring in the aspect of what's our cybersecurity aspect, what's our project management, what's our device integration. All those play an actual role in supporting the organization.
If I could, Rob,
Yeah.
one comment I wanted to make here, going back to the staffing model that I presented to finance, was showing them that you know, all I was asking for was what I needed based on the updated device hours number. Okay. Now, what I could have done is asked for more people based on what I did last year, and then when they come through with their broad brush workforce reduction initiatives, I would have some hours or a person to give, right? But I always looked at it as, look, I'm dealing with people's lives here. I don't want to hire somebody and 6 months later have to lay them off. Yeah. So I did present this to them to show them that I was being proactive, asking for less than what I would have. But 6 months from now, when you do come through with those workforce reduction initiatives, I want acknowledgement that I gave at the office. Okay, so don't include me in that. And I got it in writing from them, and there were a couple times I had to pull out that email and say, here, remember this? Oh yeah, okay, we'll go somewhere else.
Yeah.
So.
We actually tie an actual cost to the organization for each individual staff we have, starting with our support staff, engineers, project managers, everyone. There's actually a dollar value of what we are paying them and what the value to the organization is if we did not have that individual position. So when we have those conversations, when they bring in consultants and they look to reduce staff, we sit down and we have the conversation. Do we stop doing this service or do we outsource it? Because if this position goes away, one of the two has to happen, right? Either we stop providing that service or we outsource it to someone else. So this is essentially what the biomed engineering department example looks for us, right? We talk about some of those costs, right? We break them down. What's our salary, wages, benefits, supplies, support services is actually the contracts for the organization, and the other expenses as your repair budgets, training, test equipment, things of that nature are rolled up in there. I mentioned earlier about the cost of service ratios, which that's the bottom, and the operating expense ratio. So again, you can see the trend. 2012, when we started this program, we weren't looking at operating expense ratio. We were only looking at cost of service ratio. That was our initial program where we pulled all that equipment that was under full service, started bringing it in-house and developing the technicians, and started building it. So you can see as over the years, salaries have increased. We've added staff. So you can see where that cost of service ratio impacts that, right? So our operating expense over the years has increased in dollars. Our ratio has stayed the same. So when Al talked about, hey, they're adding 10% inventory, you can look at that ratio, right? Our ratio is staying the same. We built a new hospital. We added 4,000 devices. We need to budget X amount of dollars. Finance came back to us and said, we want you to keep it the same dollar amount. It's impossible to do, right? I can keep you at the same ratio though, right? I can predict to you what we need and as far as dollar amount from that aspect of it. This is the actual healthcare technology management. This is where we impact that 1,550 hours for the engineers, right? You have biomedical engineers that are out there moving equipment for people, right? They're doing device integration. They're doing cybersecurity. They're, equipment selling, disposing of equipment, entering in equipment into the database, right? What we've done is try to pull as much as that defined productive time, I like to call, away from engineers and actually get them to true productive time. An engineer, in my experience, really wants two things. They want you to train them, and they want you to leave them alone and let them do their job, right? They want to focus on repairing equipment. They want to be out there turning a wrench. They don't want to move equipment around. They don't want to sit down and do paperwork. They don't want to have to deal. Some engineers want to get in cybersecurity. Some just want to turn a wrench. So what we focused on is saying, all right, we're going to pull as much as we can away from that, let you focus on just repairing equipment, and that's how we spun up our HTM department. And you can see the growth over the years as it's actually impacted. We still want to grab value for this for the organization though, what that expense is. We look at our disposition revenue. I'm selling equipment now versus trading it in. I provide that value. I want to get credit for that as actually providing that value. We track it. We redeploy equipment, same thing. How do we actually gain value and show that to the organization? The key to all that though is having the data, actually being able to capture it and actually having the information you need. So
Yeah, when you talk about data integrity, often people look at things like consistency in manufacturer model and device category, but to me it extends well beyond that. Yes, that is important, but I talked about having a consistent set of defined work order codes that everybody is using the same way. When I first started our data cleanup initiative, I had over 150 codes in our CMMS, and I understand how that happens over the years. You have an initiative that comes up, you want to be able to track the time, so you add a code for it, right? And over time, those things build and build and build. You never seem to get rid of those, right? And so we went through and we cleaned all of that up, and we trained our technicians on what the available codes were, and with definitions, here's how you use that code. Because before, I could have 19 technicians doing the exact same work and coding it 19 different ways. Well, how can you report on anything in a meaningful way? You can't, right? So we went through that hard work of cleaning all that up, paring it down. For every request code in the database, there was a finite number of fault codes and result codes associated with that, right? And train the technicians on what those were, and it helped us maintain a very, very high level of data integrity. But as Rob said, if you don't have good data integrity, you can't improve what you can't measure, and you can't measure anything if you don't have clean and consistent data. All right, let's move on to capital budgets. Capital budgets are revenue driven, so whatever's available capital there is based on what the organization made the previous year, right? And they're typically divided into 3 buckets. Strategic, so they'll have some big initiative that's going on that they'll need to direct money at. Recurring capital is replacement of aged devices or failed devices, and then contingency capital. So they always want to hold a certain amount of money if something fails during the year that you didn't plan for, right? I would argue, and I have always argued, that if you do a better job at planning for recurring capital, you don't need to hold as much contingency capital. And that's where we're going to go through some of the models that we had for capital planning. So it's important for you to know what your organization's capital criteria is. In the 2 organizations, 2 major organizations that I worked in, it was anything over a certain dollar threshold, but a minimum of 2 years useful life. And the third criteria was that it had to be used independently. So like, for instance, a CT tube, right? Certainly it's gonna exceed that dollar threshold, but it's likely not gonna have 2-year useful life, and it can't be used independently, right? Same thing with ultrasound probes, right? So understand what your organization's capital criteria is. Your typical process is you get all of, the capital process starts, you get all these wish lists that come in from everybody, and typically what happens is whoever makes the most flowery presentation or yells the loudest is who gets the money. When I was talking to my friend CFO about this, he's like, people don't understand all of the competing priorities when it comes to capital. So he said, I love the fact that you guys came to me with this plan, this capital plan based on objective criteria, because then, okay, maybe I wouldn't make the decision to buy that thing, but even in that situation, at least I knew what the risks were if I didn't, right? And so both Rob and I are gonna go through our own plans that we had created. And your finance people will kill for that. Dave was very exasperated that he couldn't get that from the other organizations that he had gone to. And when he asked for it, they said, well, we don't have time for that. That's something you want to tell your CFO? And here's a point I want to make, and we'll make it a number of times throughout this. people shy away from some of this stuff because they assume that, well, I'm going to have to do this work myself or with the people that I have. You don't. You don't. You can easily justify additional people if you can show your finance people what savings they will get for doing this. Often in organizations, there's a capital committee that's making these decisions. Make sure that you have a seat at that table. And then once those decisions are made, they don't want all of that money being spent in January, so they'll break it out into so much per quarter as a capital allocation. And then, like I said, you should grab a seat at that table for capital planning. If you don't wait for them to invite you, just grab a seat, okay? Once they see the value that you can bring, you're not going to get anybody pushing back. So these were the assessment factors that we used. The first was the serviceability, taking into account the age factor, service cost versus purchase cost, number of service events. So if that's something that trends here, but now all of a sudden you see it climbing, you score it accordingly. Support capability, is full support available, or is it's not available from the OEM, but there's aftermarket availability, or no longer available. So when that thing breaks down, you're dead in the water, right? Equipment functional risk, we took into account probable clinical impact, probable financial impact, technology level. So if there's a major technology initiative in play, right, you leverage that in your scoring. Safety and regulatory risk. And then we created a scoring matrix around this. And what I always recommend to people is don't do this in a vacuum. Sit down with your CFO and determine and work with them to determine the appropriate scoring and weighting for each of these things, because the last thing in the world you want is to come to them with a report and they're arguing with you and debating about the validity of the numbers, right? You want to take that out of the equation. And so then here was a sample capital plan, or a capital plan based on that. So you can see in the green were the things that were good to go. The things that were in red were the things that we should consider for replacement. And the nice thing about this, and you'll see with Rob's example too, is you can see out several years. So if I decide I'm not going to replace that this year, now you understand what the impact is going to be down the road. You can't continue to kick the can down the road and expect there isn't going to be a price for it.
So just a quick plug, I'm actually going to go through these slides fairly quickly because Lonnie Bartowiak, who's our HTM program manager, is actually doing a presentation at this show later on actual capital planning and forecasting. So this is just some summaries of what we do. We actually have a 7-year fleet plan. We actually work with clinical departments, finance. We roll these things up, we combine them. We are the ones submitting the capital for the organization, not the individual departments. It gets rid of what Al talked about, the competition between who has the better presentation, who likes whoever more, right? We are actually controlling that and working with those departments. We're actually able then to forecast what the organization needs, look out at the subsequent years. So when finance sits down and says, hey, we need to be able to push this out, what is that going to impact the organization in the coming years? COVID was a perfect example, right? Everything was paused for 12 months. Well, that impacts an organization sometimes 18 to 24 months. When you're looking at capital, where you need to spend those dollars, how do you budget for it? How do you plan it out? So this is what we do from a fleet planning for our medical equipment. We have the dollars you spend. You can see the impact, how we've tried to balance it out. We push some things out from 25, now we know what 27 looks like, right? Come 26, we're going to have that discussion. Do we need to push out? Do we continue to kick that can down the road? Or do we try to just say, hey, we need these additional dollars to get us back on a balanced plan? Finance, again, numbers, right? When they see a dollar amount and they talk about, oh, I'm spending 1.6 million on patient monitoring. Well, what does that represent? That's a large dollar amount for finance to give. Oh, I don't have that. That's a bad example, right? Go down and look at EKG stress. You can actually see what the numbers actually represent, the number of devices we're buying that actually represent that cost and what that fleet is. Big one.
One thing I'd like to add to this, Rob, is what the value that this brings is, I worked in capital supply chain for an organization, and I always use the example of cath labs. We had one cath lab budgeted in a particular budget year, and we had 9 labs. And I went to the director of cardiology and I said, Noel, my guess is that you want to standardize on those labs, right? And he's like, absolutely, because I float people around. You know, there needs to be consistency in what they're using. I said, great. I'm not negotiating for 1 lab. I'm negotiating for 9. So when all was said and done, I saved a ton of money on those capital acquisitions.
So one of the things also we do is with our capital planning, we actually add notes. They need to understand what those impacts are. So why are we buying a certain thing? Why do we have to replace it, right? So we add footnotes to the bottom, right? We talk about, you know, standardization, age of equipment, right? It's information you need, so as they're looking at it, they can actually understand, sort of avoids those back and forth questions that you have with your finance department. This is a copy of our actual imaging plan. So we do fleet imaging as well, you know, imaging for imaging equipment. Again, you can see the spend, how it's, we kick that can down the road, right? We typically have $8 to $9 million. COVID hit, it parked that. Now we actually have to start spreading that out. That's when you have to start having conversations with the clinical team, your biomedical engineering team, construction services, right? We want to replace a cath lab. Well, there's construction costs associated with that. Are we going to be able to accomplish that this year? How do we plug those dollars in? How do we start managing that? Lonnie will talk into more depth because she has an hour to have this discussion, but this is some of the information that we actually share with finance to actually go through and look at those items. Again, some of the notes. Why are we replacing it? Why does it, you know, are we adding more? Are we reducing? Our goal is always to, 1, try to standardize fleet, 2, reduce the number of devices we have. We are heavy on ultrasound. We are heavy on C-arms in our organization. Pain management, two pain management rooms, 3 C-arms. Why, right? The docs someone at some point in time complained that they needed a 3rd C-arm, but you only have 2 rooms. Let's start looking at that information. When we make those decisions, we make those notes so finance can see and understand it.
Okay, so I'm going to go through this pretty quickly. We talked about staffing trends, right? We've got a lot of people retiring, not a lot of people coming in, so that's impacting our ability to do the work. So it really stresses the need to do more with less, start looking at annual device hours per technician. So one of the things that we did was we went to finance and we put together a business plan for taking on more in-house work, eliminating high dollar contracts. So we started by looking at our staff competencies. We had an assessment form that we used to at the very basic level all the way up to, you know, specific equipment, what their competency levels were, so that we knew exactly what we had in the way of talent, right, and knowledge. So once you have that, once you understand what you have in the way of competencies, now you can assess your inventory and the skills required to support that, and decide, how do I want to support it? In-house, contracted services, or outsource. And then put together a business plan. And so this is just, I'm not going to run through this, but this is just an excerpt of a business plan that we put together for our executive leadership. This is what I want to go after. And then we built it out year by year, you know, what we wanted to accomplish, and put a time frame around that. And it played into our budget, right? We talked about training. When I first went to finance, actually, they came to me. One of the CFOs in our main region came to me and said, Al, appreciate the great job you've been doing for us, but I need another $500,000 off your budget. When we were running pretty lean at the time, it was like, okay, let me see what I can do. So we went back and we did an analysis, and we had a lot of high dollar contracts on imaging equipment in particular. And so we went after that. And so I put together a business plan, and I went to him and I said, okay, if I hire this number of people and I invest in this amount of training and buy this test equipment, I can reduce our expenses on those things by 40%. Okay, and that translated into about $2.5 million. So again, when I talk about saving your organization $1 million, it's doable. Okay, and so that was very, very motivating to our team. We created a career ladder so that technicians that came to work for us knew that they had opportunities to learn and grow, get additional training, take on new modalities and new challenges. Very, very motivating. Rob can attest to the fact that we became the employer of choice in our entire region because people knew they had that ability to grow and expand. So this is just an example of the career ladder that we had for technical positions. We even had the same thing for analyst or administrative positions. So even those people had an opportunity to grow and expand. This goes back to your question where I was talking about, dividing out device hours and non-device hours. So these were typically the types of work orders that fell into device hours, those that went into non-device hours. And we were very, very aggressive at looking at every single one of these things and trying to figure out how to reduce those as much as we could. And as Rob alluded to, that's also motivating the staff. What do they love to do? Work on equipment. What do they hate to do? Administrative stuff. Let's figure out how to minimize that as much as possible. And then, as I said, the average in the industry is 1,001. We got that up to 1,550, as is Rob. I think it would be very, very difficult to improve beyond that 1,550.
For 4 years now, we've been at 1,550. It doesn't move. It's gone from 1,550 to 1,554 and fluctuates by just an hour.
So this is just a trend of those device hours. Some other opportunities, some things that you could look at that are inside the box. Auto expenses, right? I mean, because we had field engineers that traveled around, we ended up leasing fleet vehicles, and rather than paying reimbursement. We saved quite a bit of money doing that. If you were driving more than a certain number of miles per year, it was cheaper to lease a vehicle than it was to pay mileage reimbursement. Freight, shipping, again, on the front end, negotiating. If you're tight with your supply chain group, likely they have contracts, and making sure that you're taking advantage of that. We talked about capital planning, leveraging your data to drive better decisions. And again, as I alluded to earlier, negotiating all these things, parts discount, T&M labor, extended warranty, training, and service software keys, when you still have those capital dollars in hand, right? That's when you've got the most leverage. As Rob talked about, looking at these different categories, so here's your consumable med surg supplies, that's the highest number. Minor equipment, highest number. Looking at those things, they should jump out at you as things you should target for trying to reduce. Other expenses too, maintenance and service contracts, you can see is a big number. X-ray tubes. That was something that our data allowed us to create a glassware projection tool. So I could go to Toshiba or GE and say, hey, listen, I'm going to buy 5 tubes in this coming year. What can you do for me on price? Okay, and then we'd save a lot of money on that. Some things outside the box, equipment distribution. We got involved in equipment distribution because that was a way to, again, I look at this as healthcare technology management. Getting equipment to where it needs to be is part of that, right? And was able to save the organization a bunch of money. Equipment disposition. Rob mentioned this earlier, that he's got people who do that, rather than just trade in for pennies on the dollar. We sell this stuff, and we have approved vendors.
No, I was about to say, like,
right?
People.
Yeah.
Like me to buy that.
Yeah, exactly. There's tons of opportunity there. And then some revenue generating opportunities. A couple friends of mine that run some pretty progressive departments do depot repair services for other organizations. And they've gotten really good at that. And now you're generating revenue, and then offering outside services. I mean, if you know anything about TriMedics, that's how they started, as an in-house department that started selling their services outside.